Thank you very much, Ronnie, for this very, very lovely introduction, and feel the vibe. This is our first vibratory webinar, and I guess a very, very long time, and it's my great honor to welcome you to the launch webinar of the Medoc's new VSA2 for vibration sensory testing. So let's start. What we'll talk about in today's presentation will be first, we'll go a little bit into the physiological background of vibration and how it's sensed and what pathways are involved. We will talk about the similarities and differences between the VSA3000 that you may have known, our previous vibratory device, and the new VSA2. We'll also talk about some past uses because I think we can learn a lot from what has been done in the past with the VSA3000, and then I'll go into the very special features of the VSA2 as a dessert. So let's start. So you are used to me talking about thermal testing, and I just wanted to put this next to vibration testing because these are different fibers, these are different receptors, and they do different things at different speeds. And I think it's important and noteworthy to talk about that. So with thermal sensation, we are talking about receptors that are free nerve endings or multimodal receptors, and the fiber type of the peripheral somatosensory nerve fiber is the very, very thinnest non-myelinated C fiber or very thinly myelinated A delta, and these are very slow fibers. And in terms of the pathway, the thermal pathway is the first order neuron goes into the spinal cord through the dorsal horn, and there it synapses to the second order neuron, which crosses over to the anterior part of the spinal cord to the lateral spinothalamic tract, where it goes up to the thalamus, and from there to the somatosensory cortex and cingulate cortex, insula and amygdala, and all other places in the brain that are involved with thermal sensation and also pain. In terms of vibration, the first order neuron enters the spinal cord and keeps on climbing dorsally until reaching the medulla, where only there it synapses to the second order neuron. And it climbs over the dorsal column medial meniscal tract, and these are actually two columns, the fasciculus gracilis and fasciculus cuneatus. And the difference between those two is that the fasciculus gracilis transfers vibration sensation originating from the skin, and the fasciculus cuneatus transfers vibration sensation originating from bones and ligaments. And from the medulla, we go on through the thalamus to the ventral posterolateral nucleus, and from there to the primary somatosensory cortex. And why is this important to know? For instance, a spinal cord injury, the localization and the lateralization of the injury will be much better localized with vibration sensation than with thermal sensation, where there is crossing over of the second order neuron that takes about 1 to 3 segments. So there is some overlap, and the laterality is not always very precise. And this is an interesting phenomenon to look at when you are researching spinal cord injury. Of course, with regard to other tests for these types of fibers with vibration, you can use, of course, the tuning fork, and with nerve conduction studies, and with thermal testing, you can use, for instance, the CHEPS, which the TSA2 can do, and for instance, skin biopsy. In terms of vibration sensitive receptors, there are two in our body that are vibration sensitive, and the most superficial one that you can see here in the blue circle is the myasthenic corpuscle, and these are existing in the glabrous skin that we have on the palms of our hand, the palms of our feet, on our lips, on our eyelids, and also some other places. And these are mostly sensitive to very, very fine touch. So if I want to separate two pieces of paper, for instance, those are myasthenic corpuscles that do that, and very low frequency vibration. Additionally, there is a hypothesis that myasthenic corpuscles are involved with pain sensation as they express substance P, which is part of the inflammatory soup. Pacinian corpuscles, here at the bottom and circled in green, are present in the hairy skin and in the deeper layers of the skin, as well as in the joints and ligaments. And they are sensitive to a very high frequency vibration and also to deep pressure. So now that we are convinced that along with thermal testing, we also want to use vibration sensation testing, we want to know, well, why not use the tuning fork? What's wrong with the tuning fork? Nothing wrong with the tuning fork. Great device, been along for hundreds of years, but technology has advanced, and I think it allows us to map the human body and human functioning a little bit better than the tuning fork could do. And this was researched by Makutsi et al. These are researchers from Sydney, Australia, and they compared the VSA3000 handheld, the VSA3000 desktop, and the tuning fork one to the other in terms of repeatability and precision. And he tested 50 healthy participants and compared these three devices in test-retest, and these test-retests were about 15 minutes apart with the same assessor. And they found actually that the handheld VSA was most sensitive to detecting differences between body sites and differences between ages of the different participants. And you can see that on the very left side of the histogram. So the medium gray, that's the one, that's the handheld where you do the vibration perception threshold. The middle one, the black one, is where they do vibration disappearance thresholds with the VSA. And of course, the tuning fork is the light gray one, and this is where they do, of course, also vibration disappearance threshold, because with the tuning fork, we are banging the tuning fork on the edge of the bed, putting it against the skin of the patient, and the patient needs to indicate when they no longer sense the vibration. And you have to keep in mind that, especially when you use bony surfaces, there will be some resonation of the vibration into the bones, and this will also affect the vibration sensation. So they found actually that a very high repeatability between sessions and the intra-class correlation coefficient for the handheld VSA of 0.74 to 0.95, depending on the body size that was used with the handheld device. So a few more advantages of computerized vibration sensation testing that we know from the VSA3000, and we know the VSA2 will do, and maybe even better, is that it removes bias. And some of the bias that we have when you use a tuning fork is that, for instance, the amount of pressure that we apply to the body is maybe different. The amount of how hard we hit the tuning fork against the edge of the bed may be different between assessors. So we have a lot of standardization that the VSA2 allows, which is not something that the tuning fork is able to do. Additionally, there are very high resolution results, and with the graduated tuning fork, these are actually through two triangles, and you have to see where they intercept. And then exactly when the patient says, "Now I no longer feel it," then you have to look and you see where they intercept, and that's the result. And of course, it's a very low resolution results, because it's a scale from 0 to 8. So that's the maximum resolution that you can get. And of course, in terms of statistical analysis, it's much nicer to get your answers in microns with 2 decimals after the comma. And of course, it's really, really easy to record and interpret the results. At the end, the patient is pressing the patient response unit, and the result is noticed right away in the software, and there is no delay in reaction time of the assessor. So we have very easy results that we can see in our reports, and we could also export to Excel. And of course, when we have it in our software, we can compare the tests before and after intervention of the same patient, or between now and next year when they'll come back for another assessment. So these are also the options that our software allows you to use. And of course, we have the ability to test detection threshold, so where the amplitude increases until the patient senses it, or disappearance thresholds where the amplitude decreases until the patient no longer senses it, like is the case with the tuning fork. And This is not rare, but this is also, you can also do this with a tuning fork, but not with old vibratory device. You can use it on any body side since it's a handheld device. So let me elaborate a little bit more about the VSA2, and we will understand how it's different from the VSA3000. So the VSA2 is a standalone device, and you can get a hand-foot support, so you can standardize the patient's positioning, and you can make your patient more comfortable with these hand-foot support. Soon we'll have merged software, so you can do the thermal testing and the vibratory testing on the safe patient quite easily, and you can have all results on the same page, for instance. But another very special thing about the VSA2 is that you can test different frequencies of vibration. So the VSA2 is able to test between 50 and 350 hertz, and you can input the frequency that you want to use when you set up the test. And in terms of the amplitude will be between 0 and 130 microns, and this very much varies per frequency, but these are laws of physics. As soon as the frequency increases, the amplitude decreases. And there is a standardized pressure of the device of 0.5 Newton. It doesn't matter how you are in terms of gravity forces, and also which assessor uses it. The pressure will always be 0.5 Newton. So let's go over to the VSA3000 and understand the differences. The VSA3000 was an add-on device to the TSA 2001 and TSA-II later on. You could also buy a standalone, and it came with this box, and this the VSA2 doesn't come with a box. It connects directly to the computer, so you have only the handheld device. And so you had many different configurations. The frequency was only one frequency, about 100 hertz. You have to remember that this device was released somewhere in the 90s, so technology has improved and has gone a long way since, and the amplitude was between 0 and 130 microns. So why should we even talk about the VSA3000 if we already established that it's quite a different device from the VSA2? Let me just get a sip of water. Well, I think we can learn quite a lot from the VSA3000 in the sense that there is quite a lot of publications that were done with the VSA3000. We have another 100 peer-reviewed publications and full access that I have, at least in my file. And we can learn about what body sites have been used and what age groups of patients have been tested on. We can learn about what research and clinical applications may be interesting for vibratory testing, and I'll show you a couple later on. And also what vibratory testing can be indicatory for. So let's go into the body sites, for instance. The most commonly used body sites for vibratory testing. Anybody guess? It's the big toe. And of course, the big toe is the furthest away from the brain. So in length-dependent neuropathies, will we be very interested in looking at the furthest place from the brain where we can test, and this is the big toe. But there is also the fingers and the thumb, which are very interesting as they are also very much involved in our activities of daily living, and often involved in neuropathies as well. And the foot dorsum and metatarsal head, which is the pillows beneath your foot, the hand dorsum, the tenar eminence, but also even the face. And there have been some studies done on the face, for instance, in dry eye disease. Shoulders, chest, abdomen, forearm even, but also male and female genitalia. And in terms of the genitalia, you could look, for instance, at erectile disorder based in diabetic patients, or in vibration sensation testing in female pain syndromes like vulvodynia. On the thigh, on the calf, on the malleolus, but there have been also some studies done on the level of injuries, for instance, a spinal cord injury, or at the most painful site. So you can see, you name it, we've got it. Testing has been done almost at any body site, and this is why for us it was very important that the VSA2 would be a handheld device, so you could use it anywhere on the body that you're interested in researching. In terms of the types of research that have been done, of course, carpal tunnel syndrome is a very interesting syndrome, as this is a syndrome where there is a compression neuropathy. The big fibers pass under the very small carpal tunnel, and as soon as we have a menopause or any other or pregnancy where there is some swelling of the body, then there is some compression, and then we can have some very unfortunate results of it in carpal tunnel syndrome. And Tamborin looked at vibration detection thresholds in the median area and found that they were significantly different according to the neurographic severity of the carpal tunnel syndrome. And you can see that this here in extreme carpal tunnel syndrome, that's the played one over there, and it would differ from the negative, the mild, and the moderate carpal tunnel syndrome, but also the severe, those are the horizontal lines. Carpal tunnel syndrome differed from negative and moderate carpal tunnel syndrome. And all in all, if we look at vibration detection thresholds in carpal tunnel syndrome, the patients with carpal tunnel syndrome in black on the left side had almost 3 times the vibration detection thresholds of those that did not have carpal tunnel syndrome. So this is interesting to note, and this just shows that vibration detection threshold is a very sensitive tool to look at carpal tunnel syndrome. But all hope is not lost, of course. If you have carpal tunnel syndrome, you can opt for endoscopic carpal tunnel release. And we know that if you, and Kosevich research this, that if you follow these patients, and she followed them for 18 weeks after their release, the vibration detection threshold significantly improved. Not totally normalized, but significantly improved after the carpal tunnel release. And also this was connected to the severity of the carpal tunnel syndrome before getting surgery. But also so did the thermal thresholds, by the way. They also significantly improved. Another syndrome that I would like you to be aware of is the hand-arm vibration syndrome. And the hand-arm vibration syndrome is a syndrome where vascular and nerve damage occur as a consequence of exposure to vibration. And this is usually occupational exposure. So we are talking about people using drills, people using hammers, but also dentists using dental drills. And the symptoms of the hand-arm vibration syndrome are pain, paresthesias, intolerance to cold, and whitening of the fingers. One of the first signs of this syndrome is that vibration detection threshold deteriorate. In this study, they found that electroneurography results were found to have moderate correlation to vibration detection thresholds as measured with the VSA3000. And why am I telling you this? Because the European Directive 2002-44 EC vibration of OSHA has employers, they have to test their employees that are exposed to vibration on a regular basis to make sure that they do not catch hand-arm vibration syndrome. And one of the ways to do this surveillance is, by the way, with vibratory testing. In chemotherapy-induced peripheral neuropathy, we know that chemotherapy agents like taxanes and platinum agents are known to have their effect on sensation, which can be tested psychophysically with vibration sensation testing. And in this study, for instance, they looked at, they had physical therapy interventions for breast cancer patients receiving taxanes, and they followed them throughout the chemotherapy treatment with a 6-month follow-up. And they tested on the pulp of the index finger with the method of levels. And what they found was that actually those that were more physically active in comparison to those who were less physically active, and they filled a questionnaire to validate this, preserved the vibration detection thresholds. So those that were less physically active had a deterioration of the vibration detection threshold. So this is an interesting treatment efficacy measure that they found. Classically, in diabetes, we know that there is a good chance, based on your age and how long you have been suffering from diabetes, to get diabetic peripheral neuropathy. And in this study, in 19 patients with type 1 diabetes, they followed them up for 4 years after testing them on baseline, and they tested vibration sensation thresholds on these patients on the dorsal lateral aspect of the foot. And 18% of these patients developed diabetic peripheral neuropathy after 4 years. And among the variables that predicted 4-year neuropathy incidence was vibration sensation threshold with 75% sensitivity. Also note, please, that cold detection threshold has had also very high predictive values. In type 2 diabetes, the diabetes that is most prevalent, it was this important study from Brazil where they had a very large cohort of 426 type 2 diabetic patients, and they tested vibration sensation on both feet. And at the end, they took the mean of both of them because they found no significant differences between left and right, also in those developing neuropathy. So we know that this confirms that this is distal symmetrical polyneuropathy. And they found that they compared vibration sensation to the neuropathic disability score and the NDS here on the top, and also to the neuropathy symptom score, the NSS, here on the bottom. And the NDS score, there were statistically significant differences between mild and absent neuropathy and mild to moderate and severe neuropathy. And the NSS, there was no difference between no neuropathy and mild neuropathy, but there were differences between the different levels of severity of neuropathy in terms of vibration sensation thresholds. And the odds ratio show that those with vibration detection thresholds higher than 8.9 had a 3-fold chance of developing neuropathy. But let's go to children, because it's always good to talk about children. And Williams studied idiopathic toe walking in otherwise normally developing children between the ages of 4 to 8 years old and compared them to age and gender matched peers who do not toe walk. And they tested this with the method of levels, and this is a great method to use with children because it's reaction time exclusive and it doesn't require a very fast reaction from your subject. And so we know that you can test vibration sensation threshold on 4 years old, and that's just great. And what they found was that children who do toe walk have lower vibration sensation thresholds. This means they are more sensitive to vibration than those who do not toe walk. And their explanation is that higher sensitivity for vibration in toe walking children could be functional changes at the receptor level, or maybe even generally heightened sensitivity to sensory input, as is often seen in children diagnosed with autism spectrum disorder, even though none of the children at the time of the study were diagnosed, but we know that toe walking is quite common in autism spectrum disorder. Well, from children, let's go over to the other side, to the older adults. And this is a huge study of which I'm a huge fan, the Health ABC study. And this is a population-based study on community dwelling older adults and biracial cohort. And it was established in 1997, and they recruited 70 to 79 years old seniors, and they followed them for the 10 next years. And you can see that this is a 3,000 person cohort, and actually they did vibration sensation testing on the pulp of the toe of all of these seniors. So let's see what type of statistics this can give us. For instance, they found that the vibration detection thresholds predicted the incidence of mobility disabilities. So those who were less sensitive to vibration had higher incidence of mobility disability. Also, higher vibration detection thresholds had a lower quadriceps strength. And this is a very interesting finding. They found that vibration detection thresholds were associated with high risk of dementia, and maybe vibration detection thresholds are a great measure of general neurological functioning, and could be with such a big cohort also predictive for dementia. And from chronic kidney disease, we know we have similar results also from thermal testing that it is associated with vibration thresholds. And we know also from thermal testing that as your thermal thresholds are deteriorating, the risk on chronic kidney disease increases. And many of those things, in clinical practice, we can know because there was quite a lot of normative data for the VSA 3000. There was normative data for children. There was normative data for Latinos. There were normative data gathered in the Czech Republic and in Taiwan. And of course, this is still not the case with the VSA2. And we are striving to have normative data for this device as well, so it could be used in the clinic. So we are in contact with several institutions from around the world for gathering normative data for this device, as we see this is very important for clinical use with it. So let's go now into the hardware and the software features of the VSA2. Let's go first into the multi-frequency testing. So we talked a little bit about the Meissner's and Pacinian corpuscles. Just so you know, in the skin we have several mechanical receptors present. Some of them are slowly adapting and they respond to any stimulus in a tonic fashion, but some of them are fast adapting, like the Meissner's and the Pacinian corpuscles, and they are responding phasically, and so they are best equipped to respond to vibration. And we know that the Meissner's corpuscles have their best range of reaction between 10 and 50 hertz, and Pacinian corpuscles between 250 and 400 hertz. And this we know from animal studies. Does this mean that there is no vibration between 50 and 250 hertz? No. This means that these are the frequencies that they are most sensitive to, but they also respond to other frequencies. So you can go ahead and test also between 50 and 250 hertz, as is being done with the tuning fork. Okay, so now we are talking about the realm of having a handheld device, and it's so important to have a handheld device, but it's also important to use it with ease. And one of the things that we implemented in this device is that it has a screen at the back, and it shows you in which test you are. And you can also use the start and the stop button to start the test and to stop the test. So you don't have to turn around and look at your laptop again and again. You can just concentrate on having it steady on the body part and having good contact with the patient. Well, I already spoke to you about the constant force that the device applies, and it has a probe and a lever, and you can see that if you press it harder, the lever just disappears into the device, so you just cannot press it harder, and the maximum pressure that it does, or the minimum pressure also that it does, it's a half a Newton, and it's about 1.5 millimeter skin indentation. And here's a picture of what it looks like from close by, and the vibrational forces are going up and down. Irrespective of the gravity forces, you can use it in any position that you want. It has the exact same vibration in all positions, and just so you know, this is quite a technical accomplishment. In terms of the PC requirements, if you are looking into buying a VSA2, please consider that you have to have USB-C Thunderbolt, and you can see that encircled on my computer over here, because that's the amount of current that the device needs to reach higher amplitudes. An option in our software is in the limits test to have a different starting level, so you don't necessarily need to start from 0. You can start from anywhere between 0 and the first test result. So for instance, if I'm doing testing on older adults on the foot, where it may take them a very, very long time to reach even closely to their threshold, I can choose to start at 60% or 80% of the vibrational level, and then start from there. So this is what you see in the video, that we start at a higher level than 0, and this can save you time when testing. In terms of the levels test, just so you know, you can adjust quite a lot of things in the program as you are used from us. You can adjust the rates, you can adjust the duration, you can adjust the frequency. So there's quite a lot of, you can adjust the interstimulus interval. So there's quite a lot of options in our software to adjust the test and the test modality to what you are looking for, and something that would fit your research group. And I can tell you that, for instance, for the foot, you may want to use a higher rate than for the hand, as the sensitivity is much lower there, and it will take you a very, very long time if you use in a very low rate. And for the hand, I would use the lowest rate possible, as people are very, very sensitive at the tips of their fingers and may respond very early. So this is also a very precise way to measure thresholds, and we know this from literature, both from vibratory testing as from thermal testing. The levels test always has a much narrower normative data, and it's often lower than the limits test results. Just so you know, when testing, and I have now a little bit of experience testing here on my colleagues in Medoc, the sensation of vibration is very, very gentle. And from what we see here, it's quite repeatable. And when we look at stimulus to stimulus to stimulus to stimulus, it's almost, it's almost like the horizon. It's super straight. One of the things that I want to, just give you as a point of knowledge is that the 50 hertz is sent at much higher amplitudes than the higher frequencies like 100 hertz and 260 hertz. So apparently we are more sensitive there. At last, some tips for successful vibration testing. First of all, I need a very, very quiet environment. I would preferably want this environment to be without cell phones, as cell phones vibrate. We want only one thing to vibrate in the room, which is the VSA2. I want the chair to be comfortable, not like you see in the picture here. I want the patient needs to be very, very comfortable. They don't need to strain. And I would preferably like the body part that is going to be tested to be supported, so they don't need to strain to keep their body part in a specific position. And then it will be harder for them to concentrate on the vibration. And in terms of the patient, I personally very much want to say that the patient needs to be with eyes closed. It's the best way to concentrate on the vibration that you're sensing when you have your eyes closed. So I really want to expressly recommend having the patient close their eyes. They need to be comfortable and they need to be very, very concentrated. And then, as in all QST, I think familiarization is very, very much important. I think it's always good to do 1, 2, 3 simulations before starting the official testing, so that the patient knows what to expect and what type of vibration it feels like. It feels totally different than your phone. The phone is, designed for everybody to feel it in any situation. Here we are looking at the first moment vibration is sensible. So we need to very concentrate, and we need to know what type of vibration we are looking for as we start testing. So to recap, what is new with the VSA2? It's a handheld device. It connects directly to the laptop with a USB-C Thunderbolt. It can be used with a hand-foot support, which I very much recommend on using when you do tests on the hand and on the feet, and gives you standardization of positioning, and it's comfortable for the patient as well. We have the same standardized pressure and force in all positions, and this can lead to superior accuracy because this does not depend anymore on how much pressure this assessor puts on, in comparison to that assessor, for instance. We have multiple frequencies for testing for those who are interested in that. Very, very high resolution of results, as you have seen, and many different options and parameters that are available and adjustable in our software as you are used from us. And to summarize, vibration sensation testing is a repeatable and sensitive tool for research neurology in diabetes and pain. There's the option to differentially test vibration receptors at any body site, and it's of course, as soon as we have normative data, a very useful and non-invasive test for clinicians in neurology and endocrinology. Thank you very much for listening. I'll close my sharing now, and I'll make myself available for your questions.